Most of those patients bill them under me, but I'll have in touch with them. And I'll see my 20 to 30 or 40 patients a day, depending on how, they're working with me. He's like, it's actually an excellent business model. And, I mean, we kind of crunched all the numbers. I had it all flowed out for him. And it does make a lot of sense. And the delta in terms of the extra cost of those providers is minuscule compared to the increase in revenue that you're going to have. The problem is we operate so lean that nobody's willing to take on that interval step. And it's that little step of, okay, it's going to cost us for a quarter or maybe a half a year.
So maybe,
but then we get the return. And we've been pushing administration just to get a what are they called, allied clinician compensation plan done, and it's been 3.5 years. And
so maybe what you're saying, maybe we're using like PAs and Ps the wrong way.
Not even PAs and Ps. Look at our clinical staff. We're very lean on nurses, and if you take nurses.
No, but I mean even like I'm just thinking in terms of we were using our MPs and PAs for access. Perhaps we should be using them for maintenance.
Right.
Maybe we should be using them for because they can be their schedules will be full.
Part of the problem that we had historically, up until 3 years ago, maybe 2.5 years ago, was that locally NPs and PAs were capped at 80% of what we could bill and at a level 3. So there was no reason to do continuity care because they couldn't bill a level 4. They couldn't, spending time with the patient, you lost money. So that's why we all turned them into acute care people, because then they could turn through patients, do acute quick care, and see a big number that would support their income. Otherwise, it didn't. But you're right. In today's model, where they can bill level 4 and they get, I think it's only 85 or 90% delta, but still they're getting a much bigger piece coming in with each visit that they do versus before. So.
But if we have a.
But just go back to the clinical staff, your medical assistants. If you have that patient in the room. I always talk about, packaged with a ribbon on top of it, so that they're in the room. If you have a highly trained nurse, and it doesn't have to be an RN, but a medical assistant, that's able to get a history, able to take a strep throat visit, easy visit, to do it. But you know what happens with the strep throat visit? They take a look, they go, ooh, big ugly tonsils. They take a swab. You come in, you're like, oh yeah, you got strep throat, positive culture. Okay, let me take a look. Yeah, okay, there's no abscess. Okay, let me look in your ears. And you're gone. Well, imagine what that would be like if it was a diabetic patient. Okay, I've downloaded their glucose readings. I talked to them. I did a monofilament test, and their feet are okay. I asked them about when their last ophthalmology visit was. I did this, I did that. And then you walk in, and I'll say, hey, how's the kids? How's life going? Yeah, I see that, on your pie chart, you've only got 10% are within goal. And if we look at your flow chart of your blood sugar readings, most of them are coming down in the morning, but your evening ones are a bit high. What do you eat?
So in other words, a nurse could actually do what she's supposed to be doing.
Yeah, exactly.
No, but that's a big thing right now, because nurses, that's their thing. Their mantra, their history is patient education.
It's not unlike when you see your dental hygienist and they do all the work.
Right.
And then at the end,
the dentist
comes in, takes a look,
staff.
looks at the most pertinent things to make sure things are good, and that's the visit. And then even way short of that, when we talk about getting our staff involved, which it's no, but it's a challenge on for a variety of reasons. But,
sorry, everybody.
How about if we start with, we've talked about blood pressure, but medication reconciliation is a really useful thing, and
huge.
Something that doesn't need our training to do.
But I think a lot of the stuff that happens in our office, and maybe this is more optimistic starting, a lot of the stuff that happens in our office, people are frustrated just at the sheer volume. And Joanne and Margaret, despite the Coumadin stuff, and I don't have enough time, they like doing it.
Oh yeah,
it's interesting
because they enjoy the management aspect. They really like it.
Any project that I've had over the years where I've introduced more work to a staff member that involved clinical care or some closer relationship with a patient, there's always been the huge pushback. Oh, I hate this. But then once they're doing it, it's going to be the last thing to let go of. And even, at my old office where we went to one-to-one secretaries, and the thought, oh my God, I have steel. I've got 5 times as much as the other doctor. It's not fair. once she knew that personal touch with my patients, she wouldn't want to give that up because of that relationship that you build, and that, she was able to triage and understand, oh, that's so-and-so, okay.
Right.
No,
Well,
you're
that
right.
is a very
Absolutely.
valid fear of mine with some of our sharing that we're transitioning to with our staff, but that's probably for another conversation.
Well, that's one thing I worry about. I think it makes sense in a large practice like ours that there is sharing, and there's lots of data out there to show that for telephone support, that there's benefits of these telephone banks or off-site telephone answering. But we need to prove to the people that, whoever the consultants are that are going to come in and measure us to see if we are able to meet the criteria for advanced medical home, that we have these care delivery models. And when you have that piece carved out, you think of it as like a peace symbol, and you've got your clinical care, your administrative care, and your secretarial/access. And if you got your access people that, well, it's this, whoever. I can't say it's Betty or Susie or Mary. It's just, the telephone people, and it's these people that are in the back room that, deal with tasks. It makes me a little uncertain how that's going to be perceived, and I wonder how big groups that have gotten advanced medical home status have dealt with that issue, because I'm sure that they have.
Somebody's beaten it. It would be nice to see.
Yeah, where it's not, a
Plus, I
doc
think
and 2 staff
The
members.
problem with us is our secretaries are operators.
Right.
Whereas, in most situations, there's just like you said, there's a switchboard that really handles those calls,
Yeah,
where our secretaries are the switchboard.
right,
That's the problem.
right.
Yeah, and just a brainstorming thought. Rather than having what are you calling them? The task champions, whatever they're called. Response team. I just wonder, in this, just free flow of thought, would you do better rather than a response team and the dilution of feedback, because for us it's a different person that's touching it each time, and for the patient it's a different person touching each time. Would you do better with having a switchboard, 2 operators in the back that are doing all the telephone calls, and then disseminating from there the tasks out to the care team? So I'm teamed up with Secretary X, and she gets all my tasks coming from that operator, feeding in, and then over to me, and then back to the secretary, and they deal with it. So that the phone volume is being handled by this off-site, so to speak. Whatever it's called.
I just worry.
Switchboard.
I think that's more of a front end product.
As long as they can triage fast.
Yeah.
Because,
You know,
like
that's
they
a
said in the
interesting
morning,
thought.
at 9 o'clock, when the phones went on in the morning, or 8:30, whenever the phones rang, there were 45 phones, 45 calls in the queue.
I will say, at the practice I was at in Philly, 5 full-time doctors, 17,000 patients. We had one I totally forgot about this, but we had one secretary who was the switchboard. She had a gigantic phone, and you need appointment? Boom, because that's all she did. Oh, hi.
I see.
Hi, City Line Family Practice, you need an appointment? Boom. Hi, you need a referral? Boom. Oh, hi, you need a, boom. And that's all she was doing, and so the phones just went out.
So
to
she
the
literally
appropriate-
was like
An operator.
Marge.
Yeah.
Right.
That was a turnover job. How
No,
did
same
you do
woman
that
for a long
her?
time,
Huh?
actually.
Gee, she must have done.
She was in the middle.
Lucky.
That's kind of an interesting, yeah.
If you can triage fast, because so many of these.
Well, that's
like,
so
wow,
user
is this
dependent.
Davina?
Right.
I don't know if we can rely on one person.
So basically, you have
You
a
don't have
live
that
voice
person.
act as your phone for you.
Right.
Exactly. Instead of the.
Now, I'm sure they probably
press 2 for press.
got rid of her and hired, and have a phone tree now in place of her,
We should call.
but.
Yeah, let's call
We
it.
found a really good one.
We should call during
Go
lunch.
to she'd go to ortho a year later.
Yeah,
To train someone again.
Pardon me?
If you found a really good triage person, she'd end up going to ortho a year later, and then we'd be have an inefficient one person who couldn't do that.
So I have this other handout here on ICIC, who do the accrediting to see if you're advanced medical home compliant. So this is pulled out of, no, it's not, sorry.